Hi, I'm Andrew Davidson. I'm a neurosurgeon at the Royal Melbourne Hospital, Peter MacCallum Cancer Centre and Melbourne Private Hospital in Melbourne, Australia. I'd like to talk to you today about arteriovenous malformations of the brain, or AVMs. So what is a brain AVM? It's an abnormal tangle of blood vessels in the brain. It involves a direct connection between arteries and veins, bypassing the normal capillary system. This can disrupt normal blood flow and oxygen delivery to the surrounding normal brain tissue, and it also increases the risk of bleeding in the brain from rupture of one of these abnormal blood vessels. What causes a brain AVM? Well, the exact cause of brain AVMs is not fully understood. They're believed to develop before birth, but they usually don't cause symptoms until later in life. Only about 1 or 2% of brain AVMs are hereditary, linked to rare conditions like hereditary hemorrhagic telangiectasia, or HHT. Most of them are sporadic. So what symptoms can a brain AVM cause? Well, many brain AVMs are asymptomatic, but when symptoms do occur, they can come as headaches, seizures, neurologic deficits such as weakness or numbness or vision changes, and sometimes they present with brain hemorrhage if the AVM ruptures, and this can cause stroke or can even be life-threatening. So how do we diagnose a brain AVM? Well, if someone presents with any of these symptoms, they'll usually have a CT or an MRI scan, and that will diagnose an AVM by detecting the structural abnormalities. Sometimes a CT or an MRI is done for a different reason, and an AVM is found completely coincidentally. We'll almost always then move on to do a cerebral angiogram, which is a more detailed study looking directly at the arteries of the brain, where we map the AVM structure in more detail to help with our decision making. So how is a brain AVM treated? Well, untreated AVMs pose a risk of rupture which can cause bleeding in the brain or stroke or permanent neurologic damage. And so the decision about whether to treat an AVM depends on multiple factors, including its size, location, and the risk of complications that come with the treatment. Generally speaking, there are 4 options. The first option is observation, which includes monitoring the AVM with MRI scans. The second option is surgical resection, which involves removal of the AVM through open brain surgery. The third option is endovascular embolization, which is a minimally invasive procedure where interventional neuroradiologists perform a cerebral angiogram and then inject materials to block the abnormal blood vessels from the inside. The final option is stereotactic radiosurgery, including the Gamma Knife, which we have in Melbourne at Peter MacCallum Cancer Centre. This involves the delivery of focused radiation to shrink the AVM over time. So how do we know which treatment is best for each individual patient? Well, there is a variety of grading systems that are used, but the most common one is called the Spetzler-Martin grading system. It's a system that assigns a grade from 1 to 5 based on 3 factors: the AVM size, location, and the pattern of venous drainage. It's a useful tool, but the treatment decision depends on this and a bunch of other factors, including the patient's age, their overall health, their symptoms, and the experience of the surgical team and availability of other treatment options. The Spetzler-Martin grade is used in conjunction with other assessments to develop an individualised patient treatment plan. This usually involves discussion at a multidisciplinary meeting where neurosurgeons, interventional neuroradiologists, and radiation oncologists will discuss the relative merits and difficulties associated with each of these treatment options before presenting the patient with a consensus recommendation. One of the critical factors involved in this decision making is what is the risk of an AVM rupture? What's the risk if we do nothing? This risk depends on several factors, but generally speaking, the average annual risk of rupture is estimated to be about 2% per year. Over the lifetime, this 2% adds up, and particularly for younger patients, this risk of rupture over their lifetime becomes a significant concern. If an AVM has already ruptured once, then the risk of another rupture increases, and perhaps as high as 6% risk of re-rupture in the years that follow. Eventually, the risk of rupture will fall back down to the baseline risk of about 2% per year. And so if your AVM has been recommended for observation, what does that involve? Well, if the risks of the treatments outweigh the risk of rupture, then we'll recommend observation or watch and scan for some AVMs. And although there are no medications that reduce the risk of rupture, there's a couple of things that we can do with your help of your GP and the rest of your medical team to try and monitor for changes in an AVM that could increase the risk of rupture. We'll normally arrange for regular MRI scans and follow-ups with your neurosurgeon to make sure that you're staying well and to make sure that there's no changes in the AVM blood vessels. It's also important that you work with your GP to keep your blood pressure under control. My website has information for patients on all of the treatment options, including surgery, angiographic embolization, and gamma knife radiosurgery for brain AVMs. If you have any more questions, then please visit my website, www.asdavidson.com.au, for more information about the neurosurgical conditions I treat, including brain AVMs, and my consulting locations. Thank you for watching this video today.